Hello and welcome to the recording of the alarm part of Chapter 7. So we're going to get into different types and kinds of ventilator alarms. So one of the big things here is to understand which ones are more urgent or emergent to take care of versus ones that are more lower priority. And we're going to see different kinds and why and how we set some of these alarms. So let's get into it. So starting off, what's the point? What's the point of the alarms? Well, audible and visible alarm systems are designed to alert the clinician. It's designed to alert you of potential dangers related to the patient-ventilator interaction. This person is on life support, and so one of the concerns that we have here is if something goes wrong and a person's very unstable to begin with, that person could perish very easily or have a lot of damage very easily if we don't respond appropriately. So alarms are very, very appropriate. We need to understand if there's a current danger going on, and if there is, how are we going to address it? What specifically is going on, and then how are we going to address it? So that's one of the things that you're going to have to pay attention to is what does this alarm mean, but what does my patient look like first, right? When you walk into that room, you're not treating a machine, you're treating the patient that happens to be on that machine. So your first priority has got to be patient safety, and that's the whole point of alarms, is to alert us for a patient safety issue. Whether it's a high pressure alarm or disconnect alarm, anything like that that goes on, we need to be alerted so we can rectify that situation more effectively and quickly to help avoid potential dangers and damage on the patient. So one of the things that we have to look at is that patient-ventilator interaction. If they're working hard against the machine, that's something we need to take note of. Yes, it may not be something that they'll die right away from, right? Just working against the machine or working while they're on the machine, but we need to be able to see that and help work that, because that could make the difference of cardiac workload, that could make the difference of their tachycardia and so on and so forth. So it could make the difference in their days on the ventilator. We don't know, right? Those are all studies that should be done, but when we're looking at it right now, looking at the alarms and how the patient's interacting with the machine is going to be very important, and that's going to be a big part of what we do in critical care medicine. Yes, we do a lot of charting, of course, but the other thing is assessing the situation and adjusting to optimize patient care as a care team, right? You are a valuable part of that care team, and understanding what the alarms are, understanding how your patient's interacting with the machine is going to pay a lot of dividends, and making sure that patient has the best optimal healing experience they could have. So there are different levels of alarms. Some are super important and others not as immediate or life-threatening, but it's still important to understand what's going off and how to fix it. So know what is alarming, but still work the problem, right? If I walk into a room and I hear the ventilator alarming, I need to see, okay, that's important, right? That's going on, but what's going on with my patient? So you always start at the patient and work your way back to the ventilator, right? Always start at the patient and work your way back to the ventilator. That's going to be the big thing. So even when I would take radiology students, or when I would take other students in there, and they would ask about, okay, a person's on a ventilator going through a CAT scan procedure, and you hear the ventilator alarming, what do you do? And then a lot of them will look at a monitor, they'll look at the machine, they'll look at something like that. But you always start at the patient and work your way back to the machine. So always look at the patient first. Did their tube come out? Are they disconnected from the machine? Little things like that could happen, and you're going to recognize that right away. Or at least you should if you're starting out the patient and working back to the machine. So always start there. Start by looking at the patient, working your way back to the machine. We don't treat machines, we treat the patient, right? So treat the patient first, not the machine. They're your first priority. The patient is your first priority in this situation. Yes, we all love our machines. Yes, we love our ventilators, well, most of us. But the big thing here is to start at the patient first and then work your way back through the circuit, eventually back to the machine. And that's why I have DOPE in here. And why is that picture of DOPE here, right over there? Well, DOPE is that way of troubleshooting when you go into a patient's room. We've talked about this in other courses. D stands for dislodgement. Is the tube, whether it's the endotracheal tube or tracheostomy tube, is the tube improper placement, right? Is it too deep right? Did it main stem? Is it too shallow? Did it perforate the esophagus, right? Is there other things like that that's going on? Is the tube somehow dislodged? Is it out or too far in or in a place where it's not supposed to be? Is it subcutaneous? You see a bunch of sub-Q emphysema, right? Crepitus would be palpable in that situation. O would be obstruction. Is the tube obstructive? If I try to pass a suction catheter, will it pass? If it's a endotracheal tube patient, are they biting down on that endotracheal tube and causing an obstruction of the gas to go in and out, right? So what's going on there? Is the tube occluded or obstructed? Sometimes if the endotracheal tube moves out a little bit, like if the patient's moved around, the endotracheal tube can herniate over the tip of the tube a little bit and cause a little bit of an obstruction there. You could also see it where there's a ball valve effect that could happen with secretions or other things at the end of an endotracheal tube, where gas gets delivered and then on exhalation it closes off. It creates a one-way valve, sort of like a ball valve effect there. So that's something else to look at. Is there an obstruction of the tube? P is pneumothorax. We need to look and see if there's a possibility that there's a hole in the lung. So one of the things that we have to look at there is checking little things like, is there even chest rise? Do we have the tube in the same position and uneven chest rise? That could be a sign of a pneumothorax. What's happening with the heart rate and blood pressure? If the heart rate's going sky high and the blood pressure is starting to drop, then it sounds like that's a tension pneumothorax, right? So those are all things that you should be looking at. And the final one on here, right, it's the last for a reason, is going to be E for equipment, right? Check your equipment. When in doubt, disconnect them from the ventilator and start manually bagging that patient, manually ventilating that patient. That's going to be your way to make sure it's not equipment. If it is an equipment issue, then you can see if someone can help you out there and rectify that and get them reconnected. So that's your basic assessment. So you go into the room, you're treating the patient first, right? Not the machine, right? I know our world, we love to look at monitors. We have tons of monitors, tons of screens to look at. Look at your patient first. You're going to pick up a lot more, a lot quicker when you look at your patient first. All right, so types of alarms. So here we go. We're going to start off with low pressure alarms. So low pressure alarms, you're supposed to set around 5 to 10 centimeters of water pressure below the peak inspiratory pressure, right? Below the patient's peak inspiratory pressure. I'm not saying, hey, I set their PIPs at 40, so I'm going to set my low pressure at 30. No, right? You're going to look at what the patient's average PIP is, right? What their average PIP is, and then roughly around 5 to 10 centimeters of water below that, right? Because that's going to tell you there could be a compliance change or there could be a circuit disconnect. If I just set it for 0, then it's going to have to go to 0 before it reads a disconnect, and that could already be pretty hazardous to the way some of our patients are. That could be very detrimental. So that's why it's a little bit tighter there, especially if a patient's on a neuromuscular blockade, they're under chemical paralytics. That can make a big difference, right? They have the inability to breathe and they're disconnected. I'd want to know sooner than later. Or if there's a leak in the circuit, I want to know sooner than later, because that person cannot breathe on their own if they're under a paralytic. Or if they're on just regular mechanical ventilation, odds are they're not breathing on their own very well to begin with, and that's why they're on the machine, right? Not all patients are like that, but most will be. So it will help in detecting patient disconnections and even leaks in the system. So that's something to be very, very cognizant of when we're looking at it. What about your high pressure alarm? Well, that's usually 10 centimeters above their average PIP. So if their average PIP's 20, then we would set it at 30. If it's 30, we would set it at 40, right? So it's usually 10 above. That's a safety measure as well, because now we can see when a patient is coughing, when their secretions start to go up and their high pressures start to go up, if their compliance decreases, if there's kinks or herniation of the ET tube cuff, right? If there's kinks in the ET tube or biting of the tube or herniation in the cuff, then we can see that sooner on, right? We don't have to wait till the pressure goes to 50 or set a preset super high pressure. Why wait until that long before we can fix things? If their secretions are going higher, their airway resistance is increasing, you'd want to know about it sooner than later, so that way we avoid a potential detrimental effect on it. So that's going to be a big advantage for you by setting it 10 above the average PIP versus just setting it super high and leaving it alone. The caveat to this would be things like bronchoscopy. So always follow your hospital's policy and procedure. But if we're going to put an obstruction in the ET tube, when the high pressure alarm is hit, what usually happens is it'll terminate breath delivery. So if you put an obstruction in the tube, let's say it's a bronchoscope, right? You put the bronchoscope in the tube and we're obstructing the airway, what's going to happen, the ventilator is going to say, hey, that pressure is too high, I'm going to terminate the breath. So the patient's not going to get breath delivery. So during that procedure, something that we would do traditionally is try to take the high pressure alarm up really high, so that way the patient still gets breath delivery during that procedure. So like I said, always make sure you turn it back down afterwards, of course, but make sure you always follow your hospital's policy and procedures. It's there for safety, it's there for a reason, but that is sort of a caveat to that high pressure thing, is when we're doing that type of a procedure where we might have to take the high pressure alarm up high to allow for adequate ventilation during that procedure. Obviously, once you're done, you're going to take it back down. So that's something to be aware of. And if you don't change it during that procedure, then you need to be very cognizant of looking for signs of hypoxemia and hypoventilation very soon, right, as well, if you don't change that. What about your low PEEP or low CPAP and apnea alarms? Well, let's talk about low PEEP and low CPAP alarms first. So low PEEP or low CPAP alarms usually sit around 2 to 5 below the current PEEP. So if you have a PEEP of 6, then you would set your low pressure at 4, right? Or your low PEEP at 4, right? So that's something that you can do, and that's going to help if the ventilator has that alarm. That's going to help detect for leaks earlier on than just having it set at 0. Or 1, right? So that's going to help you identify those sooner, so hopefully that avoids any potential harm or risk, right? It's more conservative to set these tighter. There is something to alarm fatigue, and that's a whole separate video. But with setting it this way, we need to know, especially with a person that's on life support, that's a whole separate scenario, right? We kind of want these things to be there because those patients are very unstable to begin with. So this alarm will indicate the presence of a leak in the patient ventilator circuit. So traditionally, when you go into a room and you see low PEEP, low CPAP, there's a leak in the circuit, or there might be a slight disconnect. Something like that could be going on. Suction ballard could be open. Things like that could easily be the cause. So we got to watch out for that type of thing. All right, what about apnea alarms, right? So apnea alarms, they monitor mandatory or spontaneous breathing. So this is something you'll set, and traditionally you'll mirror the regular vent settings or the full support settings in the apnea mode traditionally, right? So whenever you make settings with their tidal volume, whenever you make settings with their delta P if they're in pressure control, make sure you go into your apnea alarms and to mirror those changes, right? So that way, if the patient somehow becomes apneic during a wean or something like that happens, then it's going to kick in and still give that patient full support. Right? So 20 seconds is the highest accepted maximum for allowing that patient to go without breathing. So that's traditionally a time interval that you'll set when you go into the apnea alarm mode. Big thing here is make sure that you're going to mirror the full support settings, or if you're not putting a patient in full support, that you put in full support settings into the apnea mode. So tidal volume around 6 to 8 mLs per kilo of ideal body weight, if that's the range currently, right? Rate 10 to 20 breaths a minute, right? The FiO2, a lot of times they'll have you use 100% in most policies. Other times you could use the same FiO2 the patient's currently on, or 10% above. I've seen that in NICUs where they'll just do a 10% above for those patients. So obviously pay attention to those protocols. Why would I have the FiO2 higher in apnea mode? Well, think about it. If the patient hasn't taken a breath for at least 20 seconds, is it possible that they are hypercarbic and they might need a little bit of oxygen to make up for that hypercarbia? Yeah, absolutely, right? So that's why there's a whole changing of FiO2 that could be a good thing to put in there. So usually 80 to 100% for adults is what they're looking at, but always follow your hospital's policy and procedure on that. All right, what about the intensity of the alarms? Well, most ventilators have some sort of alarm or indicator that alerts you when something is going on, right? When something is going on, if there's an electrical power failure, if someone unplugs your machine, or the electrical breaker no longer is functioning, right? If something happens there, like an electrical failure of the power to that room or to that outlet, then that's something that it should alarm you, because now, thank goodness, there's battery backup. Right? Thank goodness there's battery backup for these machines, so that could still run on a battery backup. But we need to make sure that we get power restored as soon as possible, because it's really unpredictable sometimes how long these battery lives will last. And so that's something we'll talk about. But electrical power failure, can be a life-threatening, because what can eventually happen, especially if they run out of energy, right? Sure enough, the machine can shut off, and there you go. The patient's no longer breathing on life support. They're no longer being supported at all, and it could actually stop the patient, make the patient work hard to breathe just through a circuit without any breath delivery. If there's no gas delivery to the patient, in other words, we lost pneumatic power, we lost the pneumatic driving gas flow to the patient, of course that's going to be a life-threatening alarm, because now there's no breath delivery, there's nothing to help exchange the gas. If the exhalation valve fails, that's going to be a life-threatening one, because how is the patient going to completely exhale? How are they going to get rid of that gas? Excessive gas delivery to the patient, that could be very dangerous and cause a ventilator-induced lung injury. Timing failure, like an I time too long alarm, you've seen those things. That could be a sign of a disconnect, or maybe their chest tube is leaking, right? Something like that's going on. So your response to these is going to be very significant, right? Very significant when you're looking at these. So time, inspiratory time, more than half of the total cycle time, usually will cause an alarm when we're talking about the timing failure. So to usually cause an alarm, so it'll try to end the inspiration, right, if it's more than half of the total cycle time, so that way the patient is allowed to exhale. So the whole thing here is, if you see that timing failure, that could be a sign there's a leak in the system as well. It's just not showing up. Low gas source alarms usually help us, especially if the gas source is not functioning. If for some reason the hospital area is shut down, like the gas source is shut down, we need to know sooner than later, because the microprocessor ventilators usually rely on high pressurized gas to function. So ventilators, usually a lot of them don't have a built-in compressor that they can use. So we need to get some sort of good high pressure gas source. It's great if you're at a facility that has the built-in compressors, and we have some of those in our lab here, but it's great if they do. However, if they don't, we need that pressure. We need to make sure that that patient is being adequately ventilated. So low gas source alarms usually can't be silenced, especially if the gas is critical to that ventilator's operation. They'll just keep going on until you fix the problem. So make sure the patient's being ventilated. Disconnect and bag them while you figure out why they don't have gas, right? Especially if you can't rectify the situation immediately. Other things too, potentially. So this is our second level. The one was life-threatening. This one's potentially life-threatening. So hopefully you're making a little mental list. You're like, oh, this one's only potentially life-threatening. It sounds like that's something I could ask you about. Which of the following would be potentially life-threatening? Which ones are immediately life-threatening? So make that list. Make sure you make that distinction in your studies. So little things like a circuit leak. Circuit leak could be potentially life-threatening. Traditionally, it's something tiny. Circuit's partially obstructed, could be water in the circuit, could be a filter that needs to be changed because you were nebulizing really thick stuff, or there's secretions that got into filters or HMEs. Heat humidifier malfunction is usually only potentially life-threatening, because is it immediately life-threatening? No, but if they don't have humidity, and we talked about this in the humidity lecture, if they don't have humidity for a prolonged period of time, it could lead to things like mucus plugging that could cause a pneumothorax, that could cause a severe atelectasis, that could cause an obstruction of ventilation. So yes, it can be potentially life-threatening. Is it immediately life-threatening? Not traditionally. IDE ratio is inappropriate. Usually when you try to go past a 1-to-1 in IDE ratio, you're going to get an alarm saying, hey, are you sure about what you're doing? Right? I wish it said that, but it doesn't. It just makes a bell noise. But it's going to pretty much make sure that you understand that what you're doing is going to make it a 1-to-1 ratio when we all know that the normal breathing pattern is a 1-to-2 IDE ratio. So it's just letting you know, oh, are you sure, right? Because that could be potentially life-threatening, especially on patients that have air trapping processes, that have longer or slower lung units that we need to exhale longer, like your COPD patient population. Are you sure you want that IDE to be even when, that 1-to-1 ratio, when we know that that person could have air trapping, they could have potential harm from there? So that's why it's potentially life-threatening, for sure, on that COPD patient population would be the primary application. There are others as well, but that's the primary. Inappropriate oxygen level, so the gas blender failure is not there, and sometimes it just needs to be calibrated, and that's every once in a while pressing the 100% O2 button. Obviously not why they're on a patient. Now, do we press that 100% oxygen button to pre-oxygenate before suctioning and all that when we do it? Yeah, but that oxygen sensor could need calibration. It could need to be changed as well. They can go bad. Right? Auto cycling could be potentially life-threatening because the machine's just giving breath, 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 breath without the patient wanting it and without the set rate saying that that's what's needed. So auto cycling, is your sensitivity too sensitive, right? Is your number too low there, right? So that's something that could be potentially life-threatening. Hyperventilate, cause the patient to work against it. If they're working against it, they could easily blow against it, have a pneumo, depending on their lung pathology. And then too inappropriate PEEP or CPAP levels. So if it's too low, all right, or too high, it's like, hey, are you sure you want to do this? This goes beyond normal physiological parameters that are regular, right, that are routine. So it's just alerting you. Just like the IDE alarm, it's saying, hey, this is going beyond physiological parameters for most patients. Are you sure, right? And it's there to help you understand that situation, right? All right, there's the level 3, non-life-threatening but potential source of patient harm. So these are very, very low-level ones. So things that we look at here would be like changes in their lung characteristics, like their compliance has changed, their air resistance has changed. I know that the Hamilton ventilator even has a whole graphic that's set up, the dynamic lung graphic, where you could actually see the compliance and resistance changes on there. High respiratory rate alarms usually are non-life-threatening, but potential source of harm, because why are they breathing so fast, right? Is there something underlying that I should look for and try to correct? If there's auto PEEP, if they're building up a lot of intrinsic, sneaky, occult PEEP, right, all those different terms for it, if they're trying to build that up, then that could be potential source of harm, especially if it builds up and builds up very high. So it's going to alarm, it's going to say, hey, they're not exhaling 100% of their breath, there's still a lot of pressure left over, more than what my baseline is set at, right, more than what my PEEP is set at. So changes in the vent drive, that depends on what type of machine you have, but that's something that you might see there as well. Other alarms that you could see, low tidal volume alarm, usually it's 10 to 15% below the set tidal volume is where you're going to set that. So if you have a ventilator and that's one of the alarms that you can manipulate, usually 10 to 15% below their set tidal volume is where we want to put that. So that understands, hey, if there's a leak or if there's a patient that's hypoventilating in a pressure volume targeted mode, if you will, or if they're in a pressure targeted mode, right? If they're in pressure regulated ventilation, pressure targeted ventilation, then hey, we know their tidal volume should be roughly this. And if you want to set that 10 to 15% below there, because maybe their lung compliance is decreasing and now they're starting to hypoventilate, you want to know that sooner than later, especially in a pressure control mode where the minute ventilation is very important because it changes so easily with the lung characteristics. Speaking of minute ventilation, the high minute ventilation alarm usually is set 10 to 15% below the average, or 10 to 15%, I think, above the average minute volume. So the high minute ventilation is 10 to 15% above the average minute volume. So change that from below to above. right? So that's what we're looking at there. So that's going to be very helpful when we're starting to see, why is this patient breathing faster and deeper, faster and deeper? The low minute ventilation would also be 10 to 15% below the minute ventilation alarm. So 10 to 15% below and 10 to 50% above is where you want that high and low minute ventilation alarm. So that's going to be very helpful if the patient's hypoventilating, especially if they're in pressure control ventilation, or if they're starting to hyperventilate. Is there a metabolic process? Are they developing an infection? Are they creating more CO2? What's going on, right? So we need to set that appropriately. What about a low frequency alarm, a low respiratory rate alarm? Well, usually a minimum mandatory rate that supports the patient. So remember, the minimum rate is going to be somewhere around 6 to 8 in that situation for full support. So when we're looking at this, we're going to make sure that that low frequency alarm is just appropriate. For some reason, if they're in a fully spontaneous mode, spontaneous breathing or pressure support ventilation, right, we need to make sure that that minimum rate's pretty acceptable, especially if they start to go apneic or getting close to going apneic. What about oxygen alarms, FiO2 alarms? They are also available. But they're usually 5% below the set percentage. And the whole point here is if for some reason the blended gas were to fail, or if our gas source at all were to fail or change, then that should alarm us and saying, hey, there's an oxygen alarm, and you guys might see this in the lab as well. So we have to adjust for this. So you'll see that on there, and sometimes it's a sensor malfunction as well, so that we have to check that. Oh, there's more alarms. We're not done. Low battery alarms, very helpful, especially if you're doing transport. Can be stressful, but the low battery alarms, very helpful because it helps tell you, hey, we need to find a source sooner than later, or I need to make sure I have another battery with me when we're transporting, or we need to make sure it's plugged in because obviously it's not plugged in and we're running out of battery. So something like that's going on. If the ventilator becomes inoperative, and traditionally that's going to be a high level alarm, but the ventilator is inoperative, and sometimes this happens when it fails a short self-test. RRTs will call that SSTs, or the ventilator companies will call it SSTs, short self-tests. So it'll say ventilator inoperative. In other words, it's not calibrated right. It's not going to be able to deliver a breath with reliability. So you'll see that alarm there. Circuit malfunction. Circuit malfunction can be very dangerous. Exhalation valve leak, right? Usually means, especially if we're getting water out of the exhalation container, right? Then someone may have forgotten. Traditionally it's you, but you may have forgotten to plug that back up again or something like that. Or if there's a parameter that's outside the normal range of the ventilator, right? If the tidal volume is way too big, are you sure you want a tidal volume of 5 liters, right? It's going to be making sure that anytime you go outside of normal physiologic parameters for a human, that it's going to alarm you traditionally. So ensuring the patient is receiving ventilation is the big part of the job. If you're a respiratory therapist, you walk into a room and you're not checking that the patient's ventilating, then you're doing it wrong, right? So your first thing when you walk into a room, is their patient breathing, right? No matter if it's a floor patient, pediatric through adult, whatever it is, you got to make sure that patient's breathing, right? That's kind of the gig, and that goes for people on mechanical ventilation. So ensure the patient is breathing, make sure they're receiving ventilation. Anytime you hear an alarm and you go into that room, make sure they're receiving chest rise, right? Make sure they're ventilating. And then if you have any doubt that they have chest rise, and you'll see these on the board exams, if you have any doubt that you're seeing chest rise, disconnect from the ventilator and begin manual ventilation using your resuscitation bag, right? That should be at your bedside. A resuscitation bag and mask should be at the bedside of all your life support patients, because what happens if the ventilator were to malfunction? It can happen, right? It can happen to any kind of machine that's out there. So make sure you have your backup ventilator at all times, every time you go in to see your patients. Where's my backup ventilator? Because is it possible someone knocked it on the floor, or the mask got crushed by the bed, or something like that happened? Yeah. So you need to make sure you have the ability to ventilate that patient at all times, even if by manual ventilation as necessary. right? So silence any alarms. So you go into this room, make sure that the patient is ventilating, silence any alarms, and if you need a second pair of hands in there, call for help as soon as possible. So that's going to be very important. If the ventilator can't be fixed, you might need to go grab a new ventilator and then have biomedical or start troubleshooting that ventilator, right? Check the operation manuals when time allows, especially let's say it's a low FiO2 alarm and it's something where we are sure the patient's getting it. It might be just calibrating the probe again. How do I calibrate this Clark electrode? Well, that's something we could look at the manual again with, or consult your friendly biomedical technician as well. But checking the operator's manuals for the machines that you use for life support is a good thing just to do in general, especially during orientation, to see, hey, if I see a low tidal volume alarm, what triggers that low tidal volume alarm for their algorithm? How do they have it set up? So the biomedical technicians are your friends when it comes down to it. So make sure the patient's ventilating. Silence any alarms, right? And then if you need to, get a new ventilator, and if you can't fix that ventilator, then that's when you need to alert biomed and work the problem, work the big situation. But always make sure you check and start with the patient safety first. All right, what alarm would sound if there was an obstruction in the ET tube or tracheostomy? Just take a guess. And we're going to assume volume ventilation for this little game. So pause it. You could comment, right? So pause it and see what alarm you would think that would be. So when we're looking at something that obstructs the ET tube or tracheostomy and they're in volume ventilation, it'd be high pressure alarms traditionally, especially if you have it set appropriately. Well, what could cause this, right? What could sound that obstruction in the ET tube? Well, that's going to be the big thing. It could be secretions, it could be biting, it could be a number of different things. Even patient positioning could cause the secretions to move up and cause that obstruction, especially intra-hospital transport, right? A lot of secretions can be jarred loose when you're taking these patients to CT scan or MRI or interventional radiology, you name it, nuclear medicine, right? Any of those places, when we're bouncing around, we're going up and down elevators, right? When we're changing their position, switching them from the bed to the CT scan and then back again, right? All those bumps and all those changes could easily cause some stuff to come out. All right, next question. What alarm would sound with a pneumothorax? What ventilator alarm would sound with a pneumothorax? Once again, this could be, guess what? A high pressure alarm. Right, high pressure alarm. You could also see a low tidal volume alarm, right? Especially if we're not able to deliver breaths. So that's something else that you could easily see and have to evaluate at that critical moment. So what alarm would sound with the suction catheter left in the tube? Especially if the suction catheter was still on, you could see low pressure or even high pressure. So low pressure if the suction catheter is still on could be sucking, so it could be long inspiratory time if you're in pressure control ventilation. If you have it in there, it would be low peak airway pressure. But if it's just stuck in there and it's not in suction, then that's where you could see a high pressure alarm, right, as well. So you got to watch out for what's going on there. So start at your patient, work your way back. You'll be able to see that pretty easily. What alarm would sound with a leak in the cuff or the ET tube or ET tube that's slightly extubated? Hopefully you're like, Derek, that's a low pressure, low minute ventilation, low tidal volume. Yes, all those low things would bring back low minute ventilation, low tidal volume, low pressure, right? All those things is what we would see there. What alarm would sound if the patient's in pressure support ventilation and they started to hypoventilate? Well, hopefully your low minute ventilation, low tidal volume alarm are set appropriately, right? Hopefully those are set appropriately. And if not, and they start to hypoventilate and those aren't set appropriately, then maybe you eventually get to the apnea alarm. But I would hope that you would catch it well before apnea. Hopefully your low tidal volume, your low frequency, your low tidal volume, your low frequency, your low minute ventilation alarms should be the ones kicking in here. What alarm would sound with a main stem intubation? We just intubated a patient, we're securing the tube, and then we have the tube a little too deep, right? It got pushed in somehow, right? So it's main stem. What alarm would sound there? Well, you're only ventilating one lung with the tidal volume of 2 lungs, so odds are it's probably going to be a high pressure alarm. So hopefully that exercise was a little helpful going through what alarms would go in there. So that helps you. Now, one of the things that we'll try to do in lab is to simulate some of these and get you some practice with, okay, what do I do with this alarm and what's the appropriate procedure, which ones are high level and so on. So we'll try to get you that functional use of it. So how to handle the pressure. If the high pressure limit alarm goes off, that's one of the things that we need to do to make sure that the patient's safe. Initial settings could be around 30 to 40 centimeters of water. For pediatric patients, we would traditionally set 30 centimeters of water. Like I said, your hospital policies may differ. However, this is a good general one to set your high pressure at 30 to 40, right, for an adult. Adjust 10 to 20 above the PIP, the average PIP the patient has. So if their average PIP is 15, then we would do 25, right? So that's even lower than that 30 to 40. But do I want to know when they're coughing, when they're biting on the tube, when they're having an increase in their airway resistance? Yeah, I'd rather know earlier than their PIP's getting up to 40. Right? I'm going to know about it earlier if it's set appropriately, and I can take care of it a lot quicker, right? And we can be more prophylactic in our therapy. We could be earlier on and hopefully avoid a lot of potential harm. Be careful of special situations such as bronchoscopy, where we talked about that before with the high pressure alarm. Some hospitals may want you to change that, others may not, but you got to watch out for hypoventilation and oxygenation issues if you don't. Body habitus could also be another situation. If I have someone with significant body habitus, let's say it's morbid obesity, they might need higher pressures to deliver the breath, to get the breath to there because of dynamic compliance issues, right? Moving the chest wall and abdomen out of the way is going to create a lot of pressure, of back pressure. Now, is that back pressure going to translate to lung trauma? Probably not, but we would probably need to see some studies based upon that. So things like that could play a factor there. High airway resistance conditions could easily be a high peak airway pressure situation where instead of having it at 40, I might have to do a high pressure, allow a high pressure of 50. Like I said, 50, right? I didn't misspeak there, to allow for gas just to get through the conducting zone so it can make its way to the respiratory zone. So that's something that we'll have to watch out there. So you might have to increase it just to allow for adequate ventilation until the steroids kick in, until the bronchodilators are able to kick in, right? Until we're able to get that bronchospasm under control with a high airway resistance condition. But don't forget to adjust as appropriate for that patient. You want to make sure the patient's safe at all times, and these alarms are your friend to help you make sure that they're safe and that you catch things early on. Low tidal volume could indicate a leak or disconnect, so make sure you hear that. Hear and look for that alarm, and then try to troubleshoot that appropriately. All right, first line here, beware of patients under neuromuscular blockades. Neuromuscular blockades can be very, very serious, and we do like to use those. They help reduce CO2 production. So if we already have a patient that we're using permissive hypercapnia on, we're letting their CO2 levels climb on purpose, we're letting their pH stay at a survivable level, that's going to be important because that allows that ventilator not to destroy lung tissue. It allows the lungs to recover while still keeping the patient survivable. And so when we paralyze, it's a great way to help us reduce how much work the patient has to do on the ventilator and how much the ventilator has to do to get gas into their bloodstream, because now they're no longer producing CO2. Their oxygen requirements decrease, right? It's not that they won't produce any CO2, they'll still be alive, right? But we're reducing the amount of CO2 production. We're reducing the amount of oxygen consumption. So once we reduce oxygen consumption, we can use lower FiO2s. Once we reduce CO2 production, we can use lower minute ventilations and still have adequate pHs, right? So that's the advantage there. The big disadvantage, if that patient becomes disconnected, oh heavens, right? You're going to have a big issue because they can't breathe on their own, right? We stop that all together with that neuromuscular blockade. So your high minute ventilation, high respiratory rate, those alarms, so now new subject, right? We talked about neuromuscular blockade. Those are your low pressure, low minute ventilation, low tidal volume, all those things that would indicate a leak or disconnect or hypoventilation, right? You want to make sure those are good. So now, on to the high minute ventilation alarm. Usually you want to set it 10 to 15% above the measured, whatever the patient's currently doing, 10 to 15% above that. We already talked about that with their stable minute ventilation. Why would it start to go up? Well, if they're in pain, right, anxiety, right, that could be a sedation issue. I'm not saying just to sedate them. I'm just saying it could be a pain, sedation issue, pain issue, right? We need to fix that pain issue. Sedation doesn't fix pain, right? That's a whole advanced pharmacology lecture. But we need to look at something like that could be causing high minute ventilation. What if they're running a fever, right? What happens to your metabolic rate? You're going to try to breathe faster, right? So those are all things that we need to look at with that high minute ventilation. So I want to catch that sooner than later. High respiratory rate for an adult, 30 to 40, right? And once you get to that 30 to 35 range, why are they breathing so fast? What is with that? Why are they doing that? That's something you need to troubleshoot. What's going on? Is this possibility of them having an infection? Is this a pain? Is this a sympathetic response to something, right? These alarms can be caused by anything from increased airway resistance, making them breathe faster, decreased compliance, because as their lung volumes go down, their respiratory rates go up, right? Especially if they're on pressure control, their lung volumes will go down. So they're going to try to breathe faster to make up for that minute ventilation. Pain, anxiety, all those can factor into this. But your first response shouldn't always be sedate, right? That's inappropriate. We want to make sure that the mental health of our patient is appropriate at all times. And usually we're going to have a pain scale, or not pain scale, but a sedation scale that we'll use to help us monitor that patient's appropriate sedation level. So apnea mode, right? What about apnea mode? So it's the same thing, set your same values as your full support mode, right? So same values as your full support mode. So make sure if the patient were to stop breathing altogether, they're still going to be on full support as much as possible. So the only changes that you would traditionally make in this mode is going to usually be the FiO2, where you set it a little bit higher. And that, like I said, that's traditional, where you set it close to 80 to 100%. But sometimes some hospitals be set at 10% above if they go apneic. So it just depends on the policy and procedure. But traditionally, that's the only change from your full support mode. Usually, you'll use the same type of ventilation. So if you're in pressure control mode, you'd use pressure control for your apnea mode. If you're using volume control, so on and so forth, right? Then you'd use volume controlled for your apnea mode. So traditionally you just put the same settings in that you put in their full support mode, or if you're just putting them in pressure support ventilation, then you would use full support settings in apnea mode, right? You'd use full support settings in apnea mode. The whole point of apnea mode is if the patient were to somehow stop breathing, whether it's a paralytic or something like that happens, then all of a sudden, hey, or sedation, a little too much, sedation kicks in and they hypoventilate, then we're going to be able to provide full support and make sure that patient is safe. All right, so these are the settings, right? When you put a patient in apnea settings, these settings will become the settings if your patient triggers that apnea time interval. Traditionally, we set it at 20 seconds for an adult and around 10 seconds for a neonate. They must provide, the settings that you put in must provide the minimum necessary minute volume for your patients, right? So make sure you're adjusting that. Every time you change your full support settings, you're adjusting this, but still don't make it to the point where you won't be fully supporting that patient if they go apneic. So some people may have a protocol to increase FiO2, like I was saying there in apnea mode, to help give that patient a little support as they come out of it. But that's obviously going to be varying depending on the region or the place that you practice. All right, FiO2 alarms. This is the last slide that we'll talk about here. This is obviously an oxygen sensor. So when we're looking at this, it could be a bad sensor. I've seen a couple of these in my practice for sure. And these are easily switched out even when a patient's on a ventilator. It just depends on the manufacturer and what the biomed personnel recommends. But might be just a bad sensor that needs to be switched out. It's obviously not life-threatening. It's just a sensor that needs either recalibration or changed out. It's available through all the different neonate, pediatric, and adult modes. It's usually automatically set by the company, the manufacturer of the ventilator, 5% above or 5% below the set FiO2 on the ventilator. So if you see that, that could be it. It could be a bad sensor, or it could be, gas supply failure of oxygen, right? Something like that's going on. So it's something to check into, but that's something that to be aware of, and that in some cases could be changed while the patient's on the machine. Other machines, I know the 840 by Medtronics allows you to sort of disable that alarm until they change it as well. But still, you're not going to just cover it up. You're going to make sure that you notify the proper people and get it taken care of. But that way, at least you avoid some alarm fatigue, right? But still follow the proper channels when you're doing this. So hopefully with this whole presentation, you've seen alarms can be helpful if they're set appropriately. If you're just saying, hey, I don't want to be bugged because a machine's alarming, and you set really high pressure alarms and super low, or if any, low tidal volume, low minute ventilation, low alarms, right? If you just max out your high alarms and you minimize your low alarms just as low as they can go, then how safe is that for that patient that's on life support, right? That's not very safe at all. So make sure you're setting the appropriate alarm settings. If it was you or a loved one on the ventilator, you'd want someone to have settings. You'd want things to be caught sooner than later. You'd want someone to see hypoventilation before it goes to desaturation, right? You'd want someone to catch these things sooner than later. So these alarms, especially on something like life support machines, pretty an important thing to take care of. So hopefully you see the importance and the value, and make sure you go through your numbers, what percent above, what percent below, so make sure you review those. And then also make sure you understand, how am I going to approach it? Do I start at the patient and work my way back, or do I start at the machine and work my way back? Do I just stare at the monitor the whole time, right? How do I approach these situations? So hopefully you got some good content out of it.